Senior Vice President. I'm the Senior Vice President of Intensive Clinical Services here at the Village. And I am acting as a co-facilitator for the Alternative Payments and Measurement-Based Work Group. As you can see, we've changed the name to kind of better reflect, I think, from a provider perspective, kind of some concerns about the words value-based. And so I think there was a recognition of that, and so we've changed the name to, alternative payment methodology and measurement-based care. If everybody, would take a moment in the chat and just put your name and your position and who you work for. That way we don't have to, we won't go around and do individual introductions. Today we're going to have a presentation and discussion of the Integrated Care for Kids initiative. And I think we have Jennifer Richmond from Clifford Beers Clinic and Hope Glassberg from HG Consulting, and Melanie, I hope I don't butcher this, Melanie Risacci from Clifford Beers Clinic. So I apologize if I've
super impressed because you did not botch it. Very good.
Good, thank you. So we're going to have a presentation by that group about their initiative and their work and their experience with alternative payment methodologies. I think, I don't know if we want to go over the minutes. I don't know if we need to go over the minutes from last meeting, Jeff. Okay, so we won't go over the minutes from last meeting. I don't know if there's anybody who, before we get started, because we want to give as much time to the presenters as possible, and then have some time for questions. And I think Jeff and Tim are going to help moderate the chat box for questions, correct? Okay, so they'll be moderating that and trying to help out and addressing questions. Before we move over to Tim and Jeff, just to kind of work through maybe the work and discuss again and review the work group goals. Anything anybody have that they wanted to share or put out there before we get started? Okay, quiet. All right, well then maybe, I don't know, Tim and Jeff, do you want to talk a little bit about do an overview of the goals and the deliverables and timeline before we get started with the presentation?
Jeff, I'm wondering, would you be able to take care? I'm sorry, I'm just switching over from the earlier meeting. So an earlier meeting, but so no, again, welcome everybody. Appreciate everybody's joining us. I think we are just trying to review again that our discussions here, we're pulling together as much as possible into forms of recommendations to push up to the leadership of DCF and the other 12 total state departments, other 11. And we're also hoping, as you'll hear today, some specifics around a particular project that we'll also be able to hear from some other projects where some concrete feedback will be asked of in the future. We're still trying to line up a couple of other discussions there. So Jeff, do you want to add anything?
No, nothing more to add, unless there are any questions about the goals or agenda.
Okay, so if there's no questions, about that or about anything else, why don't we give most time to the presenters to talk about integrated care for kids, and then we again, if you have questions, you can put them in the chat box, and we can try. Tim and Jeff will help moderate them, and then we should have some time for some questions after the presentation, during the presentation, and we're kind of targeting about 45 minutes, I think, for the presentation. So again, we have Jennifer Richmond from Clifford Beers, Hope Glassberg from HG Consulting, and Melanie Risacci from Clifford Beers. So whichever three of you are starting, go for it.
Thank you so much. I appreciate that, Eric. I'm going to go ahead. Can everybody see the presentation? Okay, great. And I just also want to just make a note. I know Hope is approaching her desk momentarily, so hopefully she'll be able to join us by video once we get to her sort of section of the presentation. So I just wanted to say thanks so much for inviting us first. We really appreciate being invited to this group from Jeff. Jeff is on our design group for the alternative payment model, and asked Melanie, myself, and Hope to join here today. So I really appreciate that, and wanted to also acknowledge our partners, Erica Garcia Young, who is also on this meeting from the Department of Social Services. Bill Halsey and Rod Winstead have been integral partners with us on this on the Inc. initiative. So, Erica, at any moment you want to jump in and add any content or context to the APM or anything else that we're talking about, please feel free to do so. Oops. So just in terms of the agenda for today, Melanie and I can maybe provide some introductions, and then we'll go into an Inc. overview just to kind of lay out, sort of just highlight high overview of what Inc. is. And then we'll be talking about APM parameters and workgroup detail. And then we'll have some time for Q&A afterwards. So my name is Jennifer Richmond. I am at Clifford Beers, and I'm the Inc. project director overseeing Inc. Melanie, I don't know if you want to just quickly introduce yourself, and then we'll go ahead into the presentation.
Sure. Thanks, Jen. I'm Melanie Rosacci. I'm also with Clifford Beers working on this. I'm their Chief Strategy Officer, and I'm excited to begin to talk to you about this today, and excited about the potential alignment of what we're doing with Inc. And what can be done in general statewide. So looking forward to today's conversation.
Thanks so much, Melanie. And Hope, I don't know if you can introduce yourself while you're in transit.
Sure. I don't know if you can hear me okay. Or maybe I'll introduce myself in just a couple minutes.
Yeah, well, when we get to your part, we'll introduce you. Okay, thanks, Hope. All right. So I'm going to just move on into the Inc. overview. So Clifford Beers, as many of you know, had received a CMS grant years ago for wraparound care coordination. It was a direct service grant, and we learned a lot about that grant, and particularly around sustainability. And we think that hopefully CMS heard that as well. And so that's why they built sort of sustainability into the Inc. Grant, as well as understanding and recognizing the benefits of care coordination. So Integrative Care for Kids grant was awarded through from CMS to the Department of Social Services. It was a competitive process. DSS sent out an RFP to out to the state, and CB was selected. Clifford Beers is one of 7 organizations or lead organizations to receive the award, but there are 8 awards in total. There's a state who received 2 awards. But Clifford Beers is the only behavioral health organization to receive that award. It's a 7-year grant with 2 years of planning. And then we're in the 2nd year now, and there's 5 years of implementation, which will start in 2022. It's important to note that this is not a direct service program, but really developing a system of care in New Haven. And we realize there's, multiple critical factors, if you will, required for success. The first really being that the children and families of New Haven are really helping to inform and design the system of care, but also our core child services partners, our partners in the state, play such an integral role. Our partnership council, folks that are on our design group that are really helping to provide input and recommendations that are critical to doing this work. Melanie said, we're really also just trying to, connect the dots, if you will, locally and on a state level with other initiatives and looking to align efforts, and how can Inc. kind of help pilot this and support other initiatives and remove silos, improving health outcomes for families and really promoting health equity. And as we talk about our driver diagram in a couple of slides down, you'll see that that's one of our primary aims. So there are 3 sort of main goals. Again, I know I mentioned this is a systems initiative. But the sort of primary goals are really around identification of treatment, which is based on working, with the whole family to reduce chronic stress and to reduce preventable and avoidable inpatient stays and out-of-home placements. The second goal will help to provide an integrated system of care to help children and families get their needs met related to physical, behavioral health, and social determinants of health. And the last goal, the third goal, is really to develop a sustainable alternative state payment model, which we'll be talking about today. This will help providers to get reimbursed for care coordination using Medicaid dollars. As many of you know, community-based organizations and behavioral health organizations have been providing care coordination, really relying on grant funding to provide that care coordination. So this APM will really allow for physical, behavioral health, and community-based organizations to get reimbursed through Medicaid dollars for care coordination. So our target population, and I just wanted to kind of point out this slide and the next slide was developed with the Department of Social Services and also with support and input from our statewide agencies and Partnership Council. But our target population is approximately 35,000. This is based on 2020 claims data. And it's children from ages 0 to 21 and pregnant and postpartum individuals up to 1 year who are receiving Medicaid and CHIP services and reside in one of the New Haven zip codes. And this is our aims, our sort of our driver diagram that identifies aims and primary and secondary drivers. And, there's a lot of information on this slide, but really is just looking at sort of the relationship of aims to primary, secondary drivers and measures. And I really just want to highlight here some of the critical aims that we're really striving for. The first is equity, and there, it's intentionally there, at the top because we're really hoping to develop the system of care and strive for equity in healthcare. We've seen, with COVID, the disparities in healthcare hitting Black and Brown communities disproportionately in New Haven. And in general, just disparities in healthcare, prior to COVID and thereafter. We really want to make sure that in designing INC and including the payment model, that we're, really helping to disrupt systemic racism and structures and helping to really, strive for health equity. Another aim that we're focused on is strengths-based and intensive care coordination, which is really about providing high quality, equitable care coordination, really families at the center, driving care. This is critical too. This is the main part of care coordination is that they're identifying family vision, they're driving the care plan, and really focusing on that and making sure that our providers are also, comporting with those guiding principles. Improving health, quality care, removing barriers to care, looking at having shared care plans across folks who are sort of the highest, most critical, with the critical needs, and also prevention and looking at early identification of needs for children and families for both physical, behavioral, and social determinants of health, and identifying those barriers in order to prevent hospitalizations, out-of-home placements, and other chronic conditions. We really also want to help to support young children to develop healthy strength-based approaches to their own care and for self-advocacy. And the last sort of aim is around reimbursement for care coordination. And as I said before, historically, folks that have been providing care coordination have been doing that really solely, relying on the funding of grants. And so in partnership with the Department of Social Services, and our design group members for our APM design group are really helping to develop, how the APM that will allow us to reimburse providers for care coordination using Medicaid dollars. The details are still being worked out, as you'll hear momentarily from Hope. But again, the goal is to really kind of level the playing field and to allow both physical, behavioral, and community-based organizations to provide intensive care coordination and to be reimbursed for that level of care. So I'm going to go to the next slide and I'm going to hand it. Well, first I'll ask to see if there's any questions before I move on. Hearing none, Hope, I'm going to hand it over to you.
Great. Thank you, Jen. And for those of you who I haven't met yet, my name is Hope Glassberg. I'm so happy to be a part of this conversation today. I'm an independent consultant working with the Clifford Beers team on the INC project. And just by way of very brief background, I've spent my career working in and around state and federal government, including having previously worked for the Center for Medicare and Medicaid Innovation, which is the entity that is funding and supporting INC. So, and I also spent 10 years working in safety net provider settings in the New York area Montefiore Health System in a large FQHC. So with that, let's turn to the alternative payment model parameters. So go to the next slide. Today, we'll talk to you a little bit about, I think it's actually the one after this one. Yep. So today we'll just level set and make sure we're all talking about the same thing when we're referring to alternative payment models. We'll talk a little bit about the vision of how alternative payment models are incorporated into INC, and then bring you into some of our preliminary thinking around what the alternative payment model in Connecticut for INC, for our INC project, we're starting to think will look like. And at any time, I invite my DSS colleagues on the phone here, as they are essential critical partners as we're moving through these conversations, to weigh in and add and enhance what we're sharing. So first and foremost, I think many of you may be familiar with the Center for Medicare and Medicaid Innovation, CMMI, which is leading the INC model. CMMI was created after the Affordable Care Act passed, and the intent of it, for those who might not know, was to essentially test and pilot new models of Medicare and Medicaid innovation, see if they work, and then if they do, in fact, lower costs and improve quality outcomes, to expand those models nationally. CMMI has typically done a lot of work in the Medicare space. So INC, Integrated Care for Kids, represents their first pediatric demonstration, which is really exciting and new territory for them. So key to these new models that CMMI is launching is a consideration not simply of how clinical and social services may be delivered differently to improve care for individuals and their families, but there's always, with pretty much any CMMI project, a reimbursement component. Because as a part of their foundational authority, CMMI is looking to see, can and should we pay for care in different ways to achieve different outcomes. So this framework here, just to level set and make sure we're all using the same term. There's a lot of alphabet soup, as we all know, in healthcare. So this framework, alternative payment model framework, came out of the Learning and Action Network, which is a learning collaborative established by HHS previously. And essentially what this boils down to is saying that there are a variety of types of alternative payment models in healthcare, but it essentially amounts to escalating expectations in terms of quality outcomes and increasing financial upside and downside risk. So this is just a bit of a rubric, I'd say, as it relates to INC, and as we'll share in a moment, because this is really kind of new terrain, federally at least, although not new terrain for many of the folks here and for the Clifford Beers team and DSS. The APMs we're talking about at a starting point are likely going to focus in on 2 or 3 here, and we'll share a little bit more about what we mean by that. Next slide. So this is just to share with you the fact, share a little bit more detail around what I had mentioned previously, which is that CMMI expects that all of those 7, 8 INC grantees nationally, which I might add are in very, very different reimbursement contexts. There are different geographies, different population sizes. Some of the participants are in states that have primarily managed care under Medicaid as opposed to fee-for-service. So it's a lot of thousand flowers blooming, if you will. But the linking thread here is that CMMI expects, and we do as well, that the new intervention that we're devising through this program will have a process by which we institute an APM. And this alternative payment model specifically applies to children that are in what's known as service integration levels 2 and 3, which we can expand upon if you'd like. But essentially that means individuals, children who have more intensive service needs based on an algorithm that we are developing. Next slide. So we are at the early stages of figuring out what this is going to mean in Connecticut. And we want to build off of the great work that's already been launched in Connecticut through other similar types of care coordination programs, whether we're talking about existing targeted case management programs or PCMH+. But what we do know is that we are going to be devising a per member per month payment that's going to focus, as I mentioned, on the CIL 2 and CIL 3 individuals. And what we're anticipating that reimbursement will cover is the intensive care coordination and needs assessments associated with better serving children and their families and connections to core child health and social services. This next area here is risk stratification. We want to make sure that we are grouping these individuals as thoughtfully as we possibly can, and DSS has engaged experts to help us make sure that we're doing this properly and learning from prior experience. So you can see a little bit here about the types of inputs that we're thinking about as it relates to risk stratification. And some of the items here are also indicated by CMMI. So CMMI, as one example, for the children who are defined as being CIL 3, is defining those individuals as those who are at risk for out-of-home placement as one example. So it's a combination of both inputs that are being directed by CMMI, as well as other data points that we have available to us in Connecticut. So the last piece, so we'll have figured out, and I also want to mention, this is a very data intensive endeavor, as you might gather at the front end. Before we even pay or serve anyone, we're working very, very closely with Beacon and CHN as we're figuring out what data sources are available, how do we stratify populations appropriately, and how do we have a rapid cycle learning process to make sure that we continue to refine and optimize how we're doing that. So absolutely want to acknowledge those essential partners in this exercise, because the goal here is truly to use data as much as possible at the front end to try to identify what needs individuals have, the appropriate payments, and then of course to connect them to the right service provider, so that we're limiting, of course, we're going to have our service providers participating in INC screening and assessing children and their families, but we hope that we'll have done a good lion's share of the work before that even takes place. Last but not least, after we've identified and refined the CIL levels and the inputs and conducted that stratification, we also, key to any APM, going back to that very original framework, is quality expectations. At its base, alternative payment models are essentially tying payment in some portion to outcomes rather than volume. And so these are a set of quality measures that we are thinking about, some of which are directed again by CMMI, but some of which have come through conversations with stakeholders. And this is an evolving conversation, so we welcome your feedback. But these are some of the quality metrics that we're also going to be monitoring as we continue to refine this APM. That might be the last slide on this, but yep. So let me pause there. So as you can sense, we're at early stages here. We're trying to learn from the experience thus far in Connecticut. Before we dive into questions, I'd love to invite DSS colleagues, Erica or Rod, or anyone I may have missed, if you'd like to expand upon anything that I've said.
I think we've covered it pretty good. Rod, anything you'd like to add?
No, she covered it extremely well. Thank you very much.
Great. All right, questions, with a caveat that we are still designing here, but welcome any questions that you may have. Okay, well, hearing none, then I'll kick it over to Melanie to talk a little bit more about what we've been doing in our APM work group.
Great. So the APM work group, much like this group, is really very vital to our process. So we have an overall partnership council where we just give overall updates and talk about the project in general. And then we have separate work groups for different streams of work, APM being one of those work groups. So we have people in the work group from the city of New Haven, we have local doctors, we have community medical organizations, we have other nonprofits, both that bill Medicaid and that do not bill Medicaid, but are already delivering care coordination services in New Haven and are very well-known providers. Because we are trying to build the system, we want lots of input from lots of different areas. So we're focusing on a series of design questions and work streams, some that have, most of which have been defined by CMMI. And we're really just trying to come up with general brainstorms and ideas from people that are already doing this work before we finalize what it actually is going to look like at the end. And we're defining the roles and responsibilities of providers and following up with any kind of design questions that we have. So if Jen, you go to the next slide. You'll be able to see these are some of the sample work streams that CMMI has provided for us. And this, we're using this just as a simple guide. Where we are now is we are definitely in the midst of engaging our stakeholders and really getting any kind of feedback that we can and consensus on what this is going to look like. We are also working very diligently with our DSS partners and the feds to secure which Medicaid authority we are going to use for this APM. And we are toying with a few different options. So we're really culling through all the details and what that will mean. And as we talked about, there is lots of data integration that's pretty vital to this right from the beginning, but all the way through. So working on some of the red tape of the BAAs, MOUs, data use agreements, which we have been working in partnership with our state agency partners, as well as any partners and subcontracts that we have within the Inc. work that we're doing. We're using the group to help us to set benchmarks and say what are good quality benchmarks, some of which we've reviewed so far and are some of our draft benchmarks. But again, we are in the infancy of this and absolutely welcome feedback and welcome anything that we may be missing. We actually like when people point out our blind spots because it helps make us better. So we are open to that. And then the payment mechanism, and then really readying providers. So we have providers on our group now, but there's going to be other providers that we're going to need to do some significant outreach to, recruitment of providers. So we're really doing the lion's share of the work on standing up what this payment model will look like and what the Inc. model will look like in general between now and the end of the calendar year. So then we can really start going out into the community to really talk with providers, because right now the goal is for the initial part of this authority to be effective July 1, 2022. So that's what the goal is. That's really our initial timeline to really start moving this forward. Jen, can you go to the next slide? So we are trying to get all of our work done within 6 meetings. I know Jeff knows how that feels. So this is just our initial timeline of what each of our meetings is going to look like. Again, right now we are just setting this up and testing it so it's in New Haven. And then the ultimate goal is that we show proof of concept and are able to sort of quickly move it across the state. There's no real timeline attached to that. It doesn't have to be at the end of the 7 years. So we're just working hard to get something stood up so it can really easily be replicated across the state. So this is our goal, to finish our work within 6 meetings. So then we can really start putting things together for providers. We know that it's ambitious, but the timeline on this is ambitious in general. As Jen talked about, this is a 7-year award. And they're on calendar years, and our first 2 years were planning years. So December 31st ends our planning time, and then we're starting to move into implementation, which will happen in year 3 of the grant starting in January. So there's been lots of work done even through COVID. We've been really lucky in our partners with DSS and our state ASOs to really be able to move this forward. There's massive amounts of data integration and lots of discussion of making sure that we pick the right Medicaid authority so we can be as inclusive as possible and including as many providers as we possibly can. So I'm going to stop there. So it looks like Jeff said we have questions. So we want to leave lots of time for questions. So I think we have about 15 or so minutes to answer any questions, hopefully have some robust discussion, and you guys can also help us figure out what our blind spots are.
Yes, Jeff, you had a couple to get things going. I also had a couple. So Jeff, you had put yours in the chat box. So actually, I'll just say mine and then you could read yours out.
Sure.
I don't know if mine is for Hope or for Jen or Melanie, but was part of the requirement. So when you roll out your plan, the payment plan, is it a maturing plan? In other words, or are you expected to have the full plan and that the last year is going to look just like the beginning, the first year? Or are you kind of, and so that's my first part. And the second is there ever any downside risk?
Okay, I'll take the first part of the question, and I think I'll let Hope or someone from DSS take the second part of the question. But the first part of the question is we do not have to fully have everything stood up for July 1. It's going to be a phased program, so it will not look the same at the end as it does in the beginning. And Hope, I am going to let you take the downsides risk question. I know that's one of your favorites.
Well, I'll add on, and also, again, I feel like I'm the caveat queen over here, but just that we are in active discussions with CMS around what the payment methodology will look like. So this is all, of course, subject to their approval, and DSS folks, again, feel free to jump in and keep me honest here. But I think the other thing I would add to what Melanie is saying is this is one thing we're considering as well. She's absolutely right. It's going to look different toward the end than it will at the beginning. We are actively considering whether we may begin with maybe a more limited set of quality measures to learn or to have more sort of pay for process metrics that eventually transition to outcomes, more outcome-based metrics over time. So just to say, not fully baked, but that's something that we're actively talking about to make sure that we're learning as we go forward through this. And then as for downside risk, so this is a care management payment. This is not tied at the moment to total cost of care, or if you're an FQHC or encounter-based payments or anything like that. So in that sense, it's conceivable we may over time take a portion of the care management fee and put it at risk depending on quality performance. So I guess tomato in terms of how you consider that from a risk perspective, but that's sort of the nature of the risk that we had been considering, potentially taking a portion or a greater portion of that care management fee and tying it to quality measures once we continue to learn more about how folks are performing in the first year of the program.
And that would likely come later?
Yeah, so we're talking about, again, everything is still actively being negotiated, but yes, the idea would be to phase in the risk component over time so that we learn.
Great, thank you.
But Erica, Rod, please, or Melanie, feel free to add more to what I've just said.
All set.
Okay.
Yeah. I know that there's questions in the chat, and I know that Heather Gates has her hand raised. So I don't know if you want us to manage the questions, Jeff, or you'd like to manage the questions.
I can help you out with that. I'll turn it over to Heather first, and then I imagine we'll probably get to some of my questions eventually anyway. So Heather, please go ahead.
Great, thanks. Just a question, you mentioned other states participating as well. At some point, could we get a presentation, or do you have access to how they're approaching it so we could learn from other parts of the country as well?
Yeah, I'll start with that. There are other lead organizations, New Jersey, New York, Oregon, Ohio, Illinois, and absolutely one of the things that we've been doing throughout this process is working with them, having sort of meetings, with each state or each lead organization to get sort of input on the APM, but other, approaches and other strategies that you're using to do needs assessments and other parts of this, the requirements for the INC grant. So I think it's absolutely feasible, for us to, I'm thinking about Oregon in particular might be a good state to start with and see if we could set up some call with folks to, ask questions and hear how they're approaching their APM. And Hope, I know you have some connections there too. Maybe you can kind of jump in on that as well.
Yeah, and would that be absolutely, every state is as a snowflake, right? The environments, the reimbursement environments are so different in each state. But absolutely, definitely. Oregon is a state that is, Connecticut has a Medicaid fee-for-service environment, and Oregon's sort of all the way on the other side of the pendulum, and they have a very managed care oriented environment. But I do think that there could be some really interesting, actually, cross-fertilization and collaboration between the two states, because they, like Connecticut, are doing a lot in terms of leveraging data sources at the state level to inform the risk stratification approach, to try to do as much kind of data work up front to try to connect people with the right care and the right providers.
So I'm just thinking, thank you, Heather, Jeff and Eric, maybe we could swing back to Hope and then kind of canvass all the states and then see maybe what ones would be most helpful to potentially see if we can get a presentation for that as a follow-up for this group.
Yeah, that makes sense.
Yeah, go ahead, Eric, please.
No, yeah, that would make sense. That would make sense. I think, it's in many ways, there's a lot of complementary efforts, it sounds like, around the country, and learning from how other states are doing it and can build additional trust in the system, so that we know this is coming, right? As providers, we know this is coming, and so it's a lot about trust between the providers and the payers and the other systems around building these models, these alternative payment models. And so hearing what other states are doing it can be a nice opportunity to build that trust.
Yeah, I think it would be great to hear some, I would imagine the cohort of states that you just mentioned who are also maybe in their second year of INC implementation. Is that right? Okay,
Correct.
So, and I think that would be helpful to hear from them as to how they're currently thinking about this work. But then I'm also looking at some of the documents that we circulated for this work group, like the behavioral health, the document from the Center for Healthcare Strategies and the National Council for Behavioral Health, where they list a number of states that are doing behavioral health oriented APMs in their Medicaid system. And, that's a really dense document. So going through it and kind of like reading it for the third or fourth time, there may be some ideas of states or people we could approach who are maybe a little further along in implementing a behavioral health oriented APM than some of the states who are doing INC and maybe in the same place that we are in Connecticut, just kind of getting things off the ground.
If when you sort of get to a point or place where you think you guys are ready to kind of hear from some of the other lead organizations, if you could just let me know. Another state we're thinking about is Montefiore, which is the New York INC organization. A couple of us are actually meeting with them next week to talk about more in detail around just data-driven approach for needs assessment. So it would be a good opportunity for me to kind of reach out to them to see if they'd be able to, meet with this group.
That'd be great, thank you. I see Frank has his hand up.
Hi, thanks. Yeah, clearly a lot of work is going into this. Appreciate the presentation. On the one slide, I don't recall when the slide that had some outcomes and things that would be tracked. I saw, there are process things and other sort of broad metrics like ED utilization and things like that. Is anyone using other types of measurement-based care, for instance, patient family experience, or actually using measurement-based care tools to assess level of functioning of an adolescent or a child, or the PROMIS measures or depression rating scales, any really to direct clients input into their functioning and incorporating that into the alternative payment model.
So Jen and Melanie, I mean, I think that actually dovetails nicely with the suggestion to have conversation with some of the other states. And certainly I can, speak to a place like a Montefiore, which is absolutely using patient satisfaction measures, generally speaking, and doing ACEs screening and the like. I don't know whether the, organizations are taking those measures and then tying them to PMPMs that are associated with the INC implementation, but it's a great point. And it's something that we can, essentially all of the INC grantees that were in the second year of implementation, we're still in a design phase, as you hear. And so many of the states are still in the process of finalizing their Medicaid authorities and how they're going to be structuring the payment, but the point's well taken. And I think it'd be interesting to hear your feedback as well, if there were specific measures in addition to what you just shared that you think that we should be contemplating in the universe of measures that we're including.
So on that point and the previous point, Melanie and Jen, I just wondered, thinking out loud, I don't want to overwhelm your work group or our work group, but we are doing similar siloed processes. So we want to integrate, but maybe it might make sense if you guys were going to invite somebody to present to yours, if for that meeting, you would be able to open up our membership and vice versa. If we have somebody come here, we could open up to your membership just to have us all get as much exposure to some of the alternative states, to the other states to hear what their alternatives are. That might be something we could consider.
Yeah, that sounds great, Tim. Absolutely.
Okay, any other, Frank, your hand is up. I don't know if you have another question or if you're, okay. Any other questions for the presenters? Otherwise, I'm going to ask mine, just in the chat box.
Go ahead.
Mine was the first one that I asked. It gets into a little bit more about service delivery and just curiosity around whether the focus is almost primarily on provision of care coordination services, or whether you envision that part of the service delivery approach that's connected with the APM payment model would also somehow incorporate linkage to ongoing care or evidence-based treatments.
Such an excellent question. There's always this, not that you were suggesting this in any way, but anytime we deal with these payment models, alternative payment models, of course, we hope that an outcome is a connection to a regular source of community-based care, but we also have to be ensuring that, nothing is being, no wires are being tripped as it relates to referrals or anti-kickback or that sort of thing. Not that you were suggesting that in any way. It's a really interesting point. To my knowledge, I don't think CMMI has indicated, and we hadn't yet gotten to a point of thinking that maybe as a part of our universe of measures, we'd think about kind of referrals to primary care or somebody connected to a regular source of care, primary or otherwise. It'd be really interesting to hear a little bit more about, and I know you're a part of our working group, but kind of what those measures would look like. I think it's an excellent point because the model itself is really about care coordination, but of course, a key outcome that we hope comes from this is that the orchestra conductor that is the care coordinator is connecting people to the care that they need. So it'd be great to measure and ensure that people are in fact being connected to the care that they need. So great point.
I see, Mark, you came off. I didn't know if you had a question. Mark Schaeffer, did you?
Thanks, Tim. I didn't come off. I actually just parachuted in. I had a conflict. So,
okay.
So I'm late to the substance, unfortunate, but I'll catch up.
Okay, great. Thank you. Jeff, you wanted to do another follow-up?
No, I think I'm good. Well, actually, number 2 on my list in the comment box had to do with attribution methods. Can you tell us just a little bit more about how you, so I know you have planned to have a network of providers, not just Clifford Beers, badged providers, but kind of a network across New Haven. So can you tell us a little bit at this point, again, I know it's still in development, but about how you plan to attribute clients to providers?
Erica, do you want to take that answer so I don't list anything that we haven't decided yet?
Okay, I'll start by saying currently with the Department of Social Services and connection to primary care PCP provider, and that's providers who have identified and attested to be a primary care provider are attributed panels. And so we are using that process to a degree with this with this initiative, by way of identifying where we can, those Husky Health members that already have a PCP or already seeing a behavioral health practitioner. We'd like to identify that at the onset and consider that part of one of two things. A, certainly inviting them in to this initiative as an INC provider. And secondly, more importantly, to certainly have those conversations with our INC members that we've identified an attributed provider, and they would be allowed choice, free choice of who they'd like to consider getting their care coordination services from, either the provider that they've been identified that was attributed to them, or that they've selected that was their choice, or they'd be provided information about INC providers that they can choose from.
Is that a CMS requirement?
No, this is something that we've designed.
Okay, I
This
wasn't,
is
yeah. Okay, I just
initiative
didn't.
on our end.
Okay, so I just wasn't sure if that was a CMS requirement. I thought I heard that that might have been, but I never heard that confirmed. So
Not
Thank
that
you.
I'm aware of, but it's just one of the efforts that we're considering from the two previous, as it was mentioned earlier, that our two previous care coordination efforts, primarily through primary care in our person-centered medical home and our PCMH Plus program. So just taking things from what we've learned, certainly those things that worked well, and moving it forward and building from it.
yeah. So Jeff, I'll throw in a question that's similar to your third question here, because so the cool thing about your project is you are a little microcosm down in New Haven of what could come for the entire state, right? So everybody here are kind of like all ears because there's a lot of similarities. So I had a similar question to Jeff's number 3, and that is preparation. It sounds like you guys are needing to spend quite some time with those who have been identified as INC providers and those who might come in and getting them up to speed about what the whole project has been on. Can you talk a little bit about that and efforts to date and how you see that unfolding? Ultimately this for the whole state and probably for New Haven locally it's a huge shift. It's the biggest concern for providers just because payments associated and you're used to one way of payment and you're shifting to another. I'm sure there's going to be overlaps of sections of the system, but so how are you, what kind of things are you doing for the providers in New Haven, and how are you reassuring them around anxiety or worry or how it might all happen?
So I can start, and then I definitely would love for my DSS and Clifford Beers colleagues to jump in here. And I know this sounds a bit like a broken record, but some of this is going to be dictated, for better or for worse, by the CMS authority and approvals that we receive as a part of every CMS kind of formal agreement. As you all probably are aware, you have to state the provider qualifications that will be included and enable kind of a barrier to entry, if you will, into the program. We're hoping to think about this expansively and creatively to ensure that we have a wide range of providers that geographically, from a service need perspective, can best meet the needs of children and their families to deliver the INC care coordination that we're all working toward. So we are still kind of working through what's permissible, what's acceptable, what's flexible, what do we think will best serve the needs of the program in terms of the barrier to entry, if you will. But then once we work through that, which we'll be doing in quite short order, then I think the second part of your question is going to be a key point of discussion, both in the alternative payment model working group, but also another working group that we have around systems of care, where we want to come together and make sure that we're providing training and technical assistance to ensure that before this launches, that folks understand the contours of this program, know how to, fill out the proper codes and submit billing to access the payment, what the quality metrics are, and any glide paths and changes to be expected over the years. I know in other discussions, and I might turn it over to Erica or Rod to comment on this, we've talked a little bit about the training and TA that you've used in other types of payment programs like PCMH Plus, and wanting to use that as a model to have really intensive resources available to make sure that the folks who are delivering the care can focus on the care, but have the tools that they need to understand how to navigate the payment parameters. So Erica, and maybe Bill has joined us now too, and might want to say more about how we're intending to support providers as we're moving forward with the APM. So DSS colleagues, I'll turn it over to you.
I don't necessarily need to answer that. I'm happy to, but Erica, if you want to, or Rod, please.
The thought I have in mind in terms of addressing that is simply that, again, like I said before, we're taking the lessons learned well from our person-centered medical home initiative. So if folks are familiar with that, Glide Path has definitely played a large role in getting providers acclimated, primarily, I would say, to the National Committee for Quality Assurance, the NCQA, patients, that they actually go by the name of patient medical centered medical home qualifications. What we've done for this initiative is to look at that criterion, and it will serve as a base, but not necessarily what needs to be part of the system of care. We're also incorporating the elements of wraparound. And so those two are our primary, I think, base concepts of what the system of care would borrow from. But again, this is something, the system of care is still in its design phase, and it is still open to folks providing feedback on what works and what doesn't work, especially if you're familiar with these standards of care under these models. We definitely want to hear from you.
Rod, did you want to say anything before I jump in?
No, go ahead.
So again, I would just say that we are really very committed to making sure that providers are successful in this endeavor. And we're having conversations today about making sure that we're including providers that are maybe not the traditional providers that you see under Medicaid, and how to make them successful and how to support them and what kind of training they need to be successful in providing care coordination services. So we're trying to be inclusive in how we think about providing care coordination. And then that also means potentially more support for those providers and what that would look like and what do they need to be successful. So we're trying to take a inclusive and kind of expansive and equity lens in the provider network under Inc.
And I would just add to what Bill was saying, just in terms of sort of leveling that playing field so that behavioral health and community-based organizations can also, participate in as an Inc. provider and have folks attributed or beneficiaries attributed to them. We're, as everybody has said, we're still designing this, but our design groups are really helping, and providers that are on the various design groups and providing feedback. And we're really taking that to heart and bringing it back to the table to kind of rethink, approach or approaches. And in addition to that, our community health organizers, we're gearing up with talking points and tablets to go out and to start to sort of target for the 35,000 beneficiaries, the top providers, provider groups, and individual providers that are already sort of attributed initially to the beneficiaries, to start to talk about Inc., really hear from them, their concerns, barriers, areas of pain points, so that we can start to bring that back and make adjustments as well. So that is all taking place within the next fall and the next couple of months.
Okay, well, we're at about 2:54, so I wanted, I want to be sensitive to everybody's time and wrap up in the hour that we've devoted to these meetings. So, I want to thank Erica and Hope and Melanie and can't remember the other. Sorry, lost my agenda. And Jennifer, for their presentation and on Inc. and helping us kind of see kind of the model that's developing in New Haven around alternative payment models and really the longevity and the sort of a longitudinal perspective on it that allows, I think, us to see that it's really a stepwise phased-in process, and it takes a lot of collaboration. And I think, again, going back to the word that is sort of gives away my clinician background, trust, in between partners in developing alternative payment models. So, I appreciate, thank you. We appreciate the presentation. Thank you very, very much. It was really very, very interesting. Any other people have any last questions for the presenters?
Yeah, I just wanted to repeat that earlier statement I made. Bill, I don't know if you had joined us yet or not, but because the two work groups are running parallel, we talked about reaching out to other jurisdictions or states who might have already implemented this, some that might be Inc. and some that might be others, and thought that if either this group or the Inc. APM group invite somebody, that we would open up each other's attendance list to join, just for a fuller exposure to what other states are doing. And then lastly, I just also reiterated when you're on here, Bill, that again, this is great about this Inc. project, is it really is setting a stage for other activities to come out statewide that would be able to mimic and or learn from the implementation of activities in New Haven. So much appreciated.
I can't remember exactly, maybe folks at Clifford Beers know, but are we the only behavioral health lead organization in terms of the Inc. awardees?
Yes, we're the, yeah.
So it's heavy on primary care and probably some managed care in there as well, but we can certainly, maybe find some slices that would be helpful for us.
Yeah. Great. So at last minute, just to open up anybody else, it was a rich conversation, but not a huge number of questions, but a full agenda. So anybody want to throw a last minute question out there, even to think about for next time, or suggestion, or just a comment before we end the meeting? Okay, so again, I thank you, Eric, for helping to facilitate. Thanks the presenters, and appreciate always the folks from DSS to jump in. This is going to be an area for us to always come back to DSS on too in Connecticut. So appreciate everybody, and have a great rest of the afternoon. Thank you all.
Thanks, everybody.
Thank you.